Hello and welcome to my channel. My name's Peter Abraham, and today's episode I want to talk about an issue that's been ongoing in the field of hospice for a number of years, impacting a number of families and their loved ones, and that's loved ones with dementia. Now, should say earlier, I was going to say earlier this year, but it's 2025 and I'm referring to 2024. This, like all my other videos, is unedited. My feeling on that is if I'm with a patient or family, it's not like I can re-roll, it's live. So it's actually later last year, it was just a few months ago, they came out with a report that Medicare saves tens of thousands of dollars when loved ones with dementia remain on hospice longer. Now, the catch-22 at that situation, and I see it on a regular basis in different social media groups where family members are appropriately upset and crying out, my loved one's being discharged from hospice, they gained a few pounds, or they're not dying fast enough. What can I do to keep them on board? And there's a delicate balance in this situation that I'd like to discuss in this episode. So, on one hand, you have what is a federal regulation called a 6-month rule, where when I, as a registered nurse or another registered nurse, goes out to admit a loved one having any type of dementia, Alzheimer's is the most common, they have to appear, there has to be evidence that that person is going to die in 6 months or less. And here becomes the conundrum, especially for family members. Outside of the stigma about hospice that's still out and there in many places where people misbelieve that hospice is going to kill their loved one on purpose. No, we do nothing to hasten death. A lot of times when we have patients come on board, they actually live longer because of the work we do. And not that that's intentional either, it's just the way things are if our recommendations are followed. Not everybody follows the recommendations. But getting back on track with dementia patients, the family members look at cases like President Jimmy Carter, who recently passed away. He was on hospice for longer than a year. Wonderful philanthropist. Did so much great work after his presidency. But he was on hospice for over a year. Well, how is he able to stay? Is it because he was an ex-president, or is he getting preferential treatment? And hopefully that wasn't the case. If we're able to establish that even though this person who was admitted several months ago is still with us, here's why they're still on track to die in 6 months or less. Hospice is a combination of art, because only God is God, and science. The science part is we have to be able to present a case to CMS, to basically Medicare, as to why this person is still eligible to remain on hospice services. More often than not, the loved one with dementia gets admitted too early. And this is another catch-22. In the best scenario, your loved one who does have a terminal illness comes on the hospice as early as possible, so we get to know them, the person. We get to know what medications work, and not that we're forcing meds. We're recommending them at the appropriate times. But if they need a medication and they take one when they're able to articulate, this gets hard with dementia, but if they have cancer or other illnesses where they can articulate what's going on if they have an allergic reaction or it's not working as intended or has what's called a paradoxical effect, the opposite of the intended effect. They can communicate what's going on. If they come on to hospice on their deathbed, they're not talking. A lot more pressure to identify if it's an allergic reaction or a paradoxical reaction and work forward. But a lot of times, sticking with the dementia case, we admit them far too early. The family falls in love with the care that the person's receiving. The overwhelming majority of the time, yes, there are some bad players out there, but the majority of the players out there are good with good intent and having the heart for hospice. And the families fall in love like this is wonderful care, whether it's at home or at a facility, an extra set of eyes, um, lots and lots of help. And then I'm using words that the families use. We use the word discharge for failure to decline, but the families will say they're not dying fast enough. And then they lose all this extra help that they've been having. Now, yes, there's palliative care available, and I'm hoping to do more education on why and when for palliative care. But for right now, would like to talk about hospice and dementia cases. So my experience with hospice, if we admit at the right time, now for Alzheimer's patients, the best time, if all you have is Alzheimer's, if all you have is Alzheimer's, the best time is FAST 7C or greater. That's going to be the best time to admit. If there's other diagnoses going on, like they have COPD or congestive heart failure, they can come on board and maybe not even have the FAST scale involved. And if they don't have Alzheimer's, while we do not want to, kind of phrase, want to be very careful when we use the FAST scale, you still need a frame of reference. So there's a way to work with the FAST scale. And I do have a book called Mastering Dementia Staging, where you can learn on how to find the stage of dementia, regardless of whether it's Lewy body, vascular dementia. But in terms of hospice, after reading that report and working through some other books that have finished and published, my next work is going to be focusing on not only mastering when to admit hospice patients, but how to keep them. This is the report from U.S. News about how much money is being saved, and the new book is about mastering dementia admissions. So the new book will be not only to help know when to properly admit a loved one with dementia, but how to know how to keep them on board and not face the discharge issue, and to do it in a way that meets CMS guidelines. So we're staying legal, ethical, moral. We're not promoting fraudulent admissions or fraudulent recertifications. A lot of times, what ends up happening, and I've been guilty of this too, is we end up missing the subtle changes. So a lot of times when we admit loved ones with dementia, they've been coming downhill. We admit them because they've been going downhill. Then they plateau. There might be a period of time where they're actually getting, I don't want to say getting better, but they look like they're improving, for lack of better words. A case just recently in January 2025, on one of the dementia groups I participate in, family member, my mother was just going overboard over the holidays and gained 5 pounds. And now the hospice agency is removing her. And the question that comes up, and I don't know the answer to this. So when I go over this, I'm not saying, oh, the other hospice agency or nurse failed. I'm not stating that. But I question, was something missed? When they went over the IDG discussion, were they looking at medication changes? Were they looking at DME changes? How often were they interviewing the facility staff to look at behavioral changes? Were they looking at how often this person needed assistance with activities of daily living? Were they taking longer to eat meals? Were they losing attention during the meals and need to be redirected to the meal? These subtle changes are declines. Now, part of the reason that I feel it's important that we protect the patient to remain on hospice and benefit the family is I'm not doing this for the benefit of the hospice agency. I know that's going to sound weird. Peter, you're talking yourself out of a potential job, still looking. Or why don't you want the hospice agency to be happy? It's not that I don't. This is about the patient and about the family. I still remember my case from 2023 where I had an Alzheimer's patient who, when I went to the recertification meeting and I'm talking to the doctor, and the only evidence I had was that they were taking 30 minutes longer to eat. We discharged that patient, and that was in March of that year. And that Easter, only talking April, one more month, she literally came back on board actively dying. I missed getting enough evidence. I didn't dig deep enough. I'm not God. It's not like I'm beating myself up over this on any regular basis. But I don't know about you, but I don't want to repeat mistakes I've made in the past. I want to improve on a regular basis. And I want to help my fellow nurses to improve on a regular basis. So I just started this right now. I just have the introduction done. I'm hoping over the next week or two, it doesn't take me long to put together my thoughts. I already have completed the research components as to what do we need to do on an outline format. So right now it's just literally filling in the blanks. I already have the chapter structures and outlines completed. So I'm hoping that this will be a book not only to know when to admit, but how do we keep loved ones with dementia on hospice for longer while maintaining CMS guidelines. This will benefit our patients with any type of dementia. It'll benefit the families. It'll benefit any facilities that these patients are at. And yes, it'll benefit the hospice agencies as well. That's all I have for this episode. If you like what you're seeing, hit the like button, subscribe. Please feel free to comment. Thank you, and God bless.